Thank you, Teddy. I just turned it on, yeah. My mother thanks you for that kind invitation, kind introduction. So thank you very much for having me. I want to introduce you to Genome Man. That's, actually, maybe it's Genome Woman, I'm not sure. But it was a character that was made. Some of your central resources went to create a series of what are called signature initiatives for the upcoming development campaign. Johns Hopkins is just entering a $4.5 billion fundraising campaign. And there are going to be 4 or 5 signature initiatives. The Individualized Health Initiative is one of them. And Genome person was created as part of, well, they had some PR person who needed something to do, and so she created Genome Man. And then they tested it, and the people didn't like it, so they threw it away. And I picked it up out of the garbage and put it on my slides. So most of what you'll see here is picked up from the garbage. So excuse me for that. So here's one. So this is. I want you to know that one of the purposes of being here today is to try to recruit you to find yourself in the Individualized Health Initiative. We really didn't have it framed in a way that we could go out and start talking to people, but we do now. And so this is really a PR advertisement. And I want to introduce Darcy Phelan, who you all know. I think Darcy has become the first official staff leader of the Individualized Health Initiative. She really is coordinating a lot of what we're attempting to get done, and is a great partner, both as a scientist and as a coordinator. So, thank you for that. So, let me try to explain. I'm going to tell you in a minute what the Individualized Health Initiative, but let me try to what it is. But let me try to explain it in terms of this thing we all know how to do. I put this in the slide deck this morning, despite Joanne Katz is telling me never to use this. Only because we're both flying. She's flying to London today. I'm flying to Seattle, so I just was on my mind. And it's useful to think about how some things work well in society. You know, planes take off, they land just about every time. You know, and so there's a model for how information is used in airplanes that I want to just. These are the radar systems around. There's BWI right there. And here's a plane coming to land at BWI, right? And there's dozens of radar systems around the area. And what they do is they ping off of these airplanes, and they get back signals, and they sort of figure out where the airplane is. So the black dots are just all of the return signals from the radars around BWI. And you can see that the black dots are noisy. They don't exactly tell you the location because there's error in radar systems. And so what the engineers have figured out to do is they have these things called Kalman filters. Actually, Kalman filters were built by a guy named Kalman at the Applied Physics Laboratory. And all they do is they smooth out the data. So the blue line, actually the red crosses are the solutions of some sort of equation that takes the noisy data and creates a smooth trajectory, which is, you can see, quite close to the actual blue line where the airplane is. So that's and then what do we do at a key moment here? You know, somebody gets on the horn to the pilot and says, turn to 290 degrees, descend to 1,000 feet, and they give a few instructions. Unlike people, the pilots listen and they do what's told, and they safely land the plane just about every time where they intend, right? So the model here I want to talk about is the model for information. So from an engineer's perspective, now why am I talking about this? Because the Applied Physics Laboratory is one of our partners in this initiative, and I have to figure out how to sort of do homage to them. So this is what the engineers talk about in the airplane model. They talk about what they call the state of the system. They call it the state vector, right? And those are the measurements, right? But not only the measurements, but also measures of uncertainty and actually which airplane it is. And then they use these repeated measures over time, they smooth them out, and then they use that information to make decisions. Okay, so let's take human health and think about an analogous situation. So the one advantage of, well, what is the one advantage of airplanes over human health? There's actually four variables, X, Y, Z, and T, and you know everything about the airplane. Over here, it's not quite so clear. It's very much higher dimensional problem. There's genotypic information, phenotypic, behavioral information, et cetera, et cetera. But you could think of, there is a state vector, and unfortunately in health research, we don't know what it is. We might even know what the variables are, but we don't measure it nearly as well. But if we did, imagine if we knew how to use this information, we would try to do the same thing. We'd try to figure out what was the state of health, right? And what was its trajectory, and what were these decisions that need to be taken along the way to try to land safely at a higher quality higher quality of life. So that's the analogy. And so the Johns Hopkins Individualized Health Initiative has as its focus, first it's a partnership of the health system, of the university, and the applied physics laboratory. And what we want to do is figure out how to discover and then demonstrate the use of better measures of an individual's health state, and also to learn how to guide the health trajectory in the direction that takes advantage of the unique characteristics of this person and leads us to a higher quality of life. Okay, so that's basically what it's about. But now let's go back to this analogy just for a second. What are the two big differences between the physics problem and the biology or the human health problem? Well, first is this is a low-dimensional vector. It's got only 4 dimensions, and once you know those, you know everything. You might also say that the inaccuracies in the measurements aren't that big. What's the difference here? Here we probably have thousands or maybe even millions of pieces of information. The inaccuracies are quite large, but there's another fundamental difference between the left and the right. What is that? You can
build the airplane specifications, but not the person.
Well, we're getting better at building people. Yeah. We have ethical issues. Yeah, that's true. You can control the airplane much more, and the pilot listens. That's another key fact. But no, I was thinking, why is it that that Kalman filter works so well with airplanes?
Well, it's a really short time span, where this is the whole lifetime.
Well, yeah, that's true. That's true. That's true. It's a short, huh? Sorry?
Airplanes are pretty much the same.
They're all pretty much the same? Well, maybe from outer space we all look sort of like. No, the big difference are the laws of physics. Do you think, we know where this plane's going because we have very simple equations. With a little bit of data, you run the equation, you know exactly, things stay the same, you know exactly where the system will be, right? And there are no laws of biology that are quite analogous to what we have in physics, right? So now I've given this talk up at the Holman campus, and there's something called the Institute for Computational Medicine, and they are trying to find the same laws. They're building computer models of human systems. They're focusing mostly on the heart, but they start at the individual molecules and build up to a whole beating heart, and they're building equations about the whole thing. So they say, oh no, we'll just wait a few years, we'll have the same thing here. But right now, that's not the situation. Okay, so with that difference, let me just say, what do we do in the case of human health? We don't have the laws of physics. What do we do instead? So let me ask you to put your clinician hat on for a moment. Here's a 40-year-old man that presents with no family history of cancer tests. No family history of cancer, but they test positive, and they're now sitting right across the desk from you, right, looking you in the eye, and they have just tested positive for this cancer, and they're very disturbed, very upset. The wife is sitting out in the waiting room, crying. There's a lot of turmoil in the family right now, and you're the clinician. So what do, right? Think of that as the ping of the radar off the airplane. It's just come back positive for this cancer, right? But we know, just like the radar, it's a noisy measure. So what do we do instead of having the laws of physics to figure out where the airplane really is? What do? We're empiricists, right? So we go to a population of otherwise similar people who are in a similar situation. We find 40-year-old men, no family history for this particular test, and we collect data, right? And we suppose have 10,000 people who are in exactly this situation. 1,000 of them tested positive, right? And so now we're zooming in on the relevant evidence, and we see that 15 of those 1,000 people, once they were followed forward and a definitive test was done, actually had the cancer, right? So now we say to the person, well, look, that was just the measurement of the cancer, right? That's our radar signal. Let's smooth it out. Let's filter it with what we know. We can't use the laws of physics. We use empirical evidence, right? And what we do then is we see that there's a 1.5% of people in your situation actually prove to have this cancer, right? And that's how we guide the person's decision, right? So the idea, and this is an individualized decision. This is a set of data that's relevant to 40-year-old men with no family history. It'd be great if we had some other data, like something about their genome or something, but you use the data you have, and here's the relevant data. But the key thing about individualized health is it's really about population health. There's no such thing as individualized health. at least today until the laws of physics or the analogs of the laws of physics are discovered, there's no such thing as individualized health without reference populations. So really the whole talk today is about what is the role of public health. And those of you who've been in public health for a while and have thought about it, you know that public health is really individualized health. It's really about creating population evidence that's relevant to decisions we make, to guide decisions we make about individuals. Okay? So this is the canonical example. There's lots of other examples. Here's an imaging example. Here's an HIV/AIDS example. There's lots of other examples. But that's the first idea that I want to leave you with, that individualized health, people think, oh, that's different than public health. No, individualized health is population health. There isn't one without the other in the world in which we live today until such time as we discover the laws of physics for health. Okay? Now, I want to take you to the second idea, and this is the idea of a virtuous learning cycle. So I found this is the art of changing the brain, but there's this idea in education or generally in cognitive science that of how we learn. And we have these abstract hypotheses, we sort of try them out in the world, we have concrete experiences, and then we reflect on what it means, and we create new hypotheses, and we go round and round, and this article is making the point that our brain actually physically changes through that process. So this is an old idea, but I want to apply it to the Individualized Health Initiative. So here is the analog of that virtuous learning cycle for individualized health, and it starts with a population. So we're going to now try to think about how to learn about this population and this population's health, and it's exactly the same idea. We have hypotheses on the left, competing hypotheses for how to improve the health of this population. We take what we know at the moment, we put it into practice, and here practice means looking after the health of individuals within populations, right? And you might think Johns Hopkins University here, Johns Hopkins Health System here, for example, right? And we put it into practice. Some things work, some don't work. We have to measure what's happening, and we bring relevant evidence from these measurements back to reflect on the hypotheses, to update our beliefs about the hypotheses. Refined, we go back, and we go round and round. And in addition to bringing evidence back, we bring back novel questions, right? We have new questions that drive the hypotheses that lead to us putting tests into practice, getting evidence, and continuing round and round. And another thing to say about the Individualized Health Initiative, it's intended to get these cycles spinning more rapidly than they're currently capable of spinning at Johns Hopkins. Okay? So I just found a lot of these things in the thing. I thought, in case you wonder whether this is a new idea, it isn't really. So now I want you to think about the Johns Hopkins Health System as a whole series of potentially virtuous learning cycles, right? Right now they're learning cycles. Actually, I've written a computer program that I couldn't get to work well enough for today's talk. I made this slide, and it does capture the way I like to think about this, but the truth is these are nice round circles right now. Really, when you actually try to make this thing spin, it's like square and bumpy and broken, and you can't really get things going because we don't have the information we need. We don't have the IRB approved. We don't have all the things you need to make these things turn. We don't do very well. And so I've written a program that generates a bunch of random circles with random radii and sort of really bumpy surfaces, but I can't get it to look very nice so far. So maybe next time I'll show you. But anyway, so think of the Johns Hopkins Health System as a whole series of these potentially virtuous learning cycles. So for example, look down here. There's about 3 million people, I'm told, in the list of patients who come in contact with the Johns Hopkins Health System. That list, every year, that list is 3 million people long. And so you would say that if we were a world-class health center that was focused on various aspects of population health, one population we would focus on are those 3 million people who come in contact with Johns Hopkins, and we would be sure that every one of them had been optimally screened for cancer in the process of coming in contact with us, right? We would know what was the right thing. We would have an individualized protocol that when that person showed up, it would automatically trigger, and it would be a protocol tailored to them, to their situation, right? And so we don't do that right now, but imagine that population as one of interest. And now what we'd like to do is sort of have the state of knowledge about what's the best way to screen. We'd like to test how it works. We'd like to implement it first and then see how it works. We'd have hypotheses how to improve it. For example, right now we have new ways of measuring DNA in both blood and urine from particular tumors. Maybe we would be able to come up with a new assay that would prevent us from having to do colonoscopy and prostate screening and other screening techniques, so we might test it here. That would be a hypothesis. We would test it. We'd get practical data, and we'd go out. We get this thing spinning, and what would come out of this virtual cycle would be improved cancer screening as practiced at Johns Hopkins. But that's a very small part of our business, right? We have, all these different, here's all the cystic fibrosis patients, of which only a small fraction are ours, but we have people who are involved with the Cystic Fibrosis Foundation, and they actually have a role to play in the treatment of all cystic fibrosis patients in North America. And there's lots of other ones here. Here's a big one, the Johns Hopkins Employee Health Plan, right? And you could imagine that there are ways we could be iteratively improving the quality of health in our employees, et cetera, et cetera. So you get the idea, okay? So what the Johns Hopkins Individualized Health Initiative is about is taking just a few of these, 5 of these, right, and trying to figure out how to make those cycles spin faster, how to make us learn faster, and how to become a leader, really, in improving population health with a focus on using information intelligently to make better decisions about each individual. And again, this idea of the individual decision is informed by the population data. So that's the model we have. And how are we going to actually do that? It really comes down to 2 things. It comes down to dancing. No. Come on, man. Who is that? And what is this movie? Exactly. So it comes down to greasing the wheels a little bit, right? This was a hint, and this guy is stuck to his neck. So what is this? Glue. So it comes down to glue and grease. That's what the Individualized Health Initiative is really going to do. It's going to apply a little bit of grease here. It's going to apply a little bit of glue. I'm only telling you this because it is not going to replace what you do. It's not going to help organize all the people who are already trying to do this in their day-to-day lives. It's really meant to bind us together a little bit loosely so that we have a common goal, we articulate it in a common way, and we can seek common resources to make all of us more successful. Okay, so here's in fact what it looks like at the moment. It's like there's only 2 buttons I have to push, the one forward and then the one that lights up the screen like that, and I still can't figure it out. So I'm about halfway through the talk, and I will get it eventually. So this is what it looks like. What we instead of saying let's sort of solve some big problem, we said let's take 4 or 5 of those little circles and see. And right now the truth is they're like broken and they don't spin. Let's get them spinning. Right? And then let's learn from that experience about how to make the rest of them spin more quickly. What do we need to make the whole place spin better? So we've chosen 6 actually now. We have that cancer screening one I mentioned to you. We have an autoimmune disease pilot. We have it's turned into a cardiology pilot that focuses on vessel disease. We have a cystic fibrosis pilot. We have a telomere biology pilot. And we have a myostatin pathways to age-related sarcopenia pilot. And these are now being put up. Each of them has been chosen because they have the potential to spin, because they have information which is unique to that particular example. So, for example, the cancer screening, we need to know who's coming here to get screened. We need to know something about their basic comorbidities so that we can calculate their life expectancy. We need to know their age. We need to know previous labs. We also have the potential to start using genomic tests there. So this one needs certain kind of data. We can't get the data. Darcy has been leading the effort to get this data. We've been trying for months by now, almost a year, and so it's an example of something that's hard to do here, but that's exactly why we chose this pilot. It needs certain kind of data, and we're going to figure out how to solve the problem, and then try to share what we've learned from others. So each of these generates, autoimmune disease generates image data, so does the vessel disease. Cystic fibrosis has a lot of genetic and genomic and lung function data and so forth, right? So different kinds of data, therefore different sort of kinds of radars and different sets of state variables that we need to focus on. Okay, so you get the idea. Now, we've got the pilots. One big pilot we hope to be able to be given permission to work on is to actually recreate the employee health plan. We would like to have a team of the best minds at Johns Hopkins actually say, we're not just going to do employee, right now you get employee health plan here at Hopkins the same as Blue Cross Blue Shield. It's no different. There's nothing about being at Hopkins that brings any of the knowledge base here to play in your health plan. In fact, truth be told, well, I won't say it because I think this is being recorded. They are a fantastic group of people. They want to innovate, and we're going to try to help them. No, I'm serious. We're going to try to help them to innovate, but right now their hands are tied. They can't do what Johns Hopkins is capable of doing just because of the financial structure and the agreements that are in place. But one idea would be for the health plan to be able to be one of those populations and actually to create a virtuous health learning system, right, where we're actually continuously over time improving the health of our population. I imagine, this is my dream, is right now every month in the hospital, all the chiefs get together and they have a notebook and they go through their RVUs and all the metrics about the consumption of health services, you know, and the financial status of each of their departments. That's essential, it's important. In addition to that, imagine that once per month, all of the leaders, all the chiefs of the health of the population departments, right, got together. We had the cardiovascular health, we had the pulmonary health, we had the mental health, we had all the health, and they had their statistics, which were about the health of the employee health, the employees, the consumption, the trajectory, and they were talking about what interventions needed to be done, what changes need to be made to get that cycle moving more rapidly towards improved health. So that's what we're hoping to be able to do. And if we could do that here over the next 5 years, APL is a key partner because they can bring the Department of Defense to the table, and we would share what we learned how to do with the Department of Defense. Imagine they did it in a bigger population, and then we would actually have contributed to understanding how to make improved health at more affordable costs a reality in the United States. So that's our goal. These little pilot projects are going to contribute the methodology for creating improved health among our employees, which we then partner with DoD and we improve the nation's health. Obviously, these pilots have not been chosen because they are the key problems in human health. Rather, they've been chosen because they represent the kind of obstacles that we have at Hopkins. So the idea is to fix these and then to go and scale to many other areas of medicine medicine and public health where it would be important to have better systems so that we can improve employee health or population health more generally. Okay, so these exist in order to create problems, and then what we want to do is we want to have cores that help solve the problem. And these cores are really going to be cyber cores. They're going to be people like yourselves all over the institution who are going to help us solve some of these problems. So we've recruited a bunch of people to help us solve this problem. And we're hoping that after we leave, they will stay a group and we'll continue to work together. So the cores that we now are thinking about is a data science core. This is really about trying to access information. It's an informatics core. Okay, it's an informatics core. You know, I used to have informatics there, and you know why I took it down? Because I don't mind the word. Oh, they hate the word no because they wouldn't invite me to the meetings where the informatics was being touched. So I talked. So I decided to focus on other. But anyway, it is an informatics core. This is really about how to get those cycles to spin. There are methodology issues I'm going to show you in just a second. So this is bioethics, clinical trials, biostatistics, computer science. This is sort of learning. How do we learn from data? This one's about basic science discovery because a lot of what Johns Hopkins can bring to this problem is the advantage of bioscience discovery. It's the distinguishing feature for us. This is organizational models. This is sort of about human behavior and health economics and incentive structures and so forth, and then a technology development and dissemination. What we're really hoping is that as we learn to do things, that make a difference here, we'll sell that or give it to other people and make a difference outside. Okay, so I'm going to just give you a little bit of detail about a couple of these. So let me say a little bit more about the cancer screening program. So the key idea, this is, by the way, led by your own Elizabeth, your own meaning the Epi department's own Elizabeth Platts, and Bal Carter, a prostate surgeon in the Department of Urology, and a group of about 7 or 8 people who are very active. Darcy is our spiritual leader, and we meet every 2 weeks, and we are focusing on the 5 most common cancers. We're starting with prostate cancer, and the idea is to take the best knowledge we currently have about prostate cancer and screening. We happen to have the president, is he the president of the American Urologic Association, Bal Carter, and he was the person who chaired the committee, just did the new guidelines. So we have the new guidelines. We don't use them at Johns Hopkins. What we do at Johns Hopkins is whatever our doctors learned in medical school and may have looked up at a meeting or talked to a friend about. There's nothing here that makes us any better than, MedStar, right? I mean, I hate to say it, but except for the fact that we have Bal Carter here who's willing to come and share what he knows with the rest of us. So the idea is to capture what Bal knows, to put it into an algorithm, to get that algorithm and to test it in a population. And Craig Pollack has got a randomized trial across the Johns Hopkins community physicians that he's going to do to test best practice against whatever they're doing, and we'll demonstrate that it's better. We'll publish that, and science will go around. We have Ken Kinsler working with us with the possibility of bringing in a new prostate screening procedure, whole new thing. He's looking to test it at Johns Hopkins and community physicians. So we'll get that thing spinning. But it's not sufficient to do science. Really, that's the old model. You do science and you publish it. Now what we have to do is we also have to have an implementation process. So when we have this algorithm, we can't test it unless we implement it. And we have the capacity to do that now, potentially, through the EPIC system and others. And so we need a whole implementation team that's going to take what is the best algorithm, get it into practice so that we can test it, but then we can also make a difference to the lives of the people who come in contact with us. And these two things running in parallel. And this really is the virtuous circle, right? The virtuous cycle going around, and it'll improve the quality of outcomes here. So
You don't show the feedback.
yeah, didn't I not? Hold on, let's see. Go back. Oh, that's true. So this is a double-headed arrow, really. Oops. Coming back this way. So it's really going around this way. Thank you. Okay, so just to give you an idea of one pie, let me tell you a little bit about the second core, this learning health communities, because there's an enormous number of interesting problems, and I thought that given some of you would be epidemiologists and biostatisticians, this may be the kind of thing you'd be interested in. So we have a working group that's just about to be announced. Michael Rosenblum and Nancy Cass are the co-chairs. We're going to be meeting every, I think, 2 weeks, and basically the purpose of the working group is to share problems, and then as time goes on to start giving updates on what individuals have done to create solutions. And let me give you an idea of some of the kinds of problems that I'm aware of as a statistician. So in order to do this, to practice that individualized health radar screening approach, you have to be able to answer questions, routine questions like, what is the person's health state, right? So that's really asking it's not asking what was the measurement, it's asking what is the health state. So the measurement was I test positive for cancer, 40-year-old, no family history, test positive. That's the measurement. The question is, what's the health state? The health state is whether the cancer exists or not in this person, right? And so what is the person's health state given measurements to date, right? What's the person's trajectory? That's really the derivative of the health state given the measurements to date. Does a particular intervention improve health on average and for a person with a specific set of characteristics? So that's really the individualized health idea. And then, is the intervention being used optimally? So if you have a health system, you want to ask the question, suppose we know what's the best thing to do for a person with a given set of characteristics. Are we applying the intervention, are we applying the treatment optimally across the population of people? And how big is the difference that investing in that intervention, how big is the benefit of that investment? So these are the kinds of questions you have to be able to answer, analogous to asking, where is the airplane, right? And so let me just represent this as follows. So statisticians always like to use Greek letters when they don't know the thing. And this is the key idea that sort of, if you think about you're teaching Epi 1 and you have somebody who's clinically trained, the key change when they become aware of populations is that the measurements are not the thing, right? There is some underlying sort of latent state, and the measurements inform us about that latent state, but the measurement isn't necessarily the thing itself. So you have to teach them about error and measurement error and how to deal with that. So let's just imagine for a second that what we have is a change for Joe. Joe's state is changing over time. I sort of show it going down, which is unfortunate, but it's changing, right? And it's it's the aggregate of this time, this trace. This is the true blue line for the airplane. It's this that we wish we knew. And you might think that what we want to be able to do is have a number or a statement that characterizes what this is: stable, improving, deteriorating, acute deterioration. So this is just sort of a label that we might put on this state. So we want to be able to take and be able to create summaries of these trajectories, right? So, and then we want to be able to ask questions like, well, here's a treatment. RX stands for treatment, and we've applied the treatment back here, right? We applied it to the person's health state, right? So it's affecting the health state, and then the health state's changing, and maybe we keep applying it, right? And maybe there's some outside things we also have to measure. These are sort of the exogenous ones, right? And the question is, how is the trajectory changing as a result of having applied these interventions? So that's what these coefficients tell us. This tells us something about where the person was headed, what kind of person they are. This tells us whether the interventions are having any benefit. And notice that says beta sub I. Is it benefiting this person, right? That's the question. That's a different question than we usually ask. It's a harder question, right? Now, the real bugaboo here, though, is that we don't observe. There's two things. We don't observe the health state. We sort of take a measure, and maybe in some rare disease situations you actually can observe it directly with very little measurement error. You can pretend like you actually see it. But in most problems, you only get to a sort of glimpse of this from measured data, right? And so you have these measurements, and sometimes you actually don't get them. The circle means it's missing. But here's the other key idea, is that what treatments we give are driven not by the state of health, but by the state of the measurements of health. When you measure something, right, the clinician takes the measurement and decides what to do with it, right? So right now, it tends to be the measurements that drive the state of health. And that's a very dangerous system. When you have systems that you have errors and then you make decisions based upon based upon the erred measurement, you have the potential for these feedback systems which can send people way out of kilter. And if you ask the best primary care doctors at Hopkins, why is Hopkins such a great place for somebody with a very complex disease to come? Most of them tell me when I ask them, because we stop treating them with all that crap that's been developed over time. All the shit, we sort of take them all away, and we then try to figure out what are the things that will make a real difference. And that's because these people come with lots of decisions having been made, a measurement, new treatment, a measurement, new treatment. You keep loading on stuff rather than trying to understand what's the person's state and what treatment would benefit that state. Now, I'm giving a cartoon here. It's huh? A belief. It's a belief. It is. I know. It's what you've been doing for years. I know. I told you there's nothing new here. Huh? Okay. Now, the other thing to say is this is the sort of way to think about a person, right? And as Harold says, this is an example of a Bayesian belief network. I don't like the word belief necessarily, but it's okay. And he's a doctor, and it is about belief then. But the key thing is going back to the beginning. I had that one person who showed up with a positive test, and I said the only way to make sense of that is to put that person in the context of a population. So the truth is, you can't learn very much about this system from this one person, right? And if you say, oh, this one person's treatment is different, the treatment effect on this one person is different than everybody else, or this person can be characterized as being a progressor, that's only true if you have a population of people. So the schematic really says, imagine that this is what's going on for Joe, and here's Sarah, and here's Sam, and there's thousands of people, right? And they're each progressing here, and you need to somehow learn, you need to pool the information and then send that back to get better estimates of what's going on for each individual, just the way we did with that very simple cancer screening problem. So this picture is really a generalization of positive for 40-year-olds, right? And now what do? You look at a 2x2 table, and this is just a generalization of that, right? So that's and now you can use this system to answer these questions, and I'm not going to go through and talk to you about that. I do want to say one other thing about a methodology opportunity that really came out of a conversation that Joanne and I had. And imagine, Joanne Kells, she's fortunately left. So she wears this Fitbit, you know. Do you know what a Fitbit is? It's some people have the Nike version, but it's basically a machine that just measures how many steps you take each day and also how many vertical steps you take. It counts, and then it's set. It's nice. Those have been around for a long time, right? But the only difference is this thing has a little chip that sends automatically to your PC the results each day, so you can see how you're doing and you get automatic feedback. And it's possible that message could also be sent to the Johns Hopkins Employee Health Plan if you're an employee, so we could know that you're not moving so much anymore, and maybe there'd be an opportunity to. Actually, you laugh. I visited a pharmaceutical company called Janssen Pharmaceutical in New Jersey. It's been bought by Johnson & Johnson, but it's a Belgian company, very progressive. And all the employees there are a member of the health club automatically. And you go and you do whatever you do in the health club, and then they give you free Johnson & Johnson products. So right across the hall, you take your slip that you've just gone 10 miles on a bicycle, and you get a free bar of that beautiful Neutrogena soap or something like that. So people do it. And the other thing they do is if you don't show up for a while, a trainer just stops in and says, "What's going on?" Say, "Oh, I don't feel well." Well, maybe they actually are engaged in your health. Well, I don't know if we want to go that far here, but imagine. So I want you to think about the Fitbit. Actually, the conversation we were having, don't say I told you, is that actually, let me turn the microphone off here for a second. You need to be able to do more N=1 trials. So this is an idea that's out there. A lot of people have written a lot about this, but I think there's sort of a new opportunity to make this real. So you need first to be able to Fitbitize the measurements. You need to have a device that can measure the state, and we can make objective. Think of what happens if you're a gynecologist and you're trying to work with a patient. You say, well, go on hormone replacement therapy, and the person does it for 6 months and they don't like it. And they ask, how are your symptoms? Well, maybe they're a little better. These treatments don't fix the problem, for a lot of people. So maybe and you really don't have quantitative evidence. Okay, well, how are the side effects? Yeah, I really hate the side effects. Okay, well, let's go off the medication for a while. And so you go off the medication, and then you go back in 6 months. How are you feeling? And there's no quantitative. I mean, we'd never do science like that, would we? Why should we do health like that? So there's no quantitative measurements. There's no systematic evaluation. There's no experimentation, right? But it's an experiment to figure out what therapy works for you for hot flashes, or for weight loss, or for control of chronic pain, or for lots of things that people care about. So we need to be able to do the measurements. And then we need to make a list of the interventions that are available. Each has a characteristic time scale of action. So, for one of the things I saw on the web for hot flashes is people eat tofu, right? They're supposed to eat tofu because it has naturally occurring estrogens, right? So there are people out there eating tofu to control their hot flashes. Does that work? I don't have the foggiest idea. Tofu has a very short time scale of action. It's supposed to work, like within a week or two. So maybe you say that the characteristic time scale is 2 weeks. But hormone replacement therapy, you got to do that for 6 months to find out if it's beneficial. So it has a different time scale of action. There are different run-in periods, different washout periods. Now the question is how to design a cyclic, that is to say, or maybe you call it an iterative factorial design, multiple treatments that start out at a high level, trying to rule out things and focus in, and then to actually get more definitive evidence as you go. It's a fantastic research question. It's a research question for statisticians, but maybe more importantly for epidemiologists and clinicians, teams, to be able to figure out what would actually be work here. And there's lots of examples of where this would go. And the key thing here is if all you could do is ever do this once on a person, there's no hope of learning. But if you embed that person in a population of people, many of whom are doing this, you can collectively figure out what's best for the individual by having the information from the whole population. So that's an example of a really great research problem that we might work on. Okay. So one last thing I want to say before I close is there's a huge issue about how to, as I said, the big difference between the airplane and the human being is that when the pilot gets the instruction to change to a new course, a new altitude, they do it almost always. I mean, rarely say no, right? But I'm told by my clinician friends or my nurse friends or just, trainers, when you tell a person to do something, they usually say they will, but then they usually don't, right? So there's a huge aspect of human behavior here. And so studies of the behavioral economics around health are really interesting. And one of the things we have the opportunity to do in this plan, so we have proposed to the head of the health system and the head of the university the possibility of taking the 28 cents we spend for every dollar of salary at Johns Hopkins to pay for health care, 28 cents on every dollar, and putting it all together and make it 1.28, right? And then to say we have to use up to, say, 25 cents per dollar to manage the health of the population, to do all the health care that we currently provide and start to shift some of that money to do health. Over time, we want to make a shift. But if we don't use all 25 cents, right, we actually get to give the money out to the people who didn't use it. Now, you could think, well, there's a lot of options there. You could do all kinds of incentive systems, but one thing that would do is change the relationship. Right now, it's like I go get my services, you pay for it, right? And I'll go get whatever services I want. You can try to stop me, but I'm going to complain about it, and and I'm going to call you a bad insurance company. And actually, one of the reasons Johns Hopkins pays so much is we don't want to say to our employees no. Right? So our employee health plan is much more expensive than most other employee health plans because we have people who are knowledgeable about what they want, and they won't take no for an answer. And so we say yes, so we just spend all that money. What if you could get that money as income instead, right? And what if you could have better health instead, right? And we're not a particularly healthy population. So there's tremendous opportunity. And one of the things is how to communicate to people. So I want you to imagine now this pentagon. You can only ever communicate to populations of people about things they can do something about. So this is just sort of made up. I know you guys would not do this much better, but imagine there are 5 verbs: move, engage, nourish, maintain, and don't smoke, right? And this pentagon, the one that is actually a pentagon, the blue one, that's the break-even point, right? So if we hit our targets, we as a population of people hit our targets, then we get a certain minimal, it's 100%, we get our salary but nothing more, right? If you just hit your targets. And the money is represented by the area, okay? Now, the lines say how we're doing relative to the target. If you don't get to the target, it means you're not doing as well as we need to, and if you get beyond, it means you're doing better. And so this is how we're actually doing as a population, and the area is 1.2 rather than 1, right? So we actually are far exceeding our target. Why? Because we're moving a lot more and we're engaging. Engaging is really a measure of mental health. We're engaging more. We're actually being, we have better mental health, better participation in our workplace, and we're getting rid of smoking. It's going away fast. We're not doing so well in maintaining our blood lipids and blood pressure and blood sugar and so forth, and our diet could be improved, but we're doing pretty well in the other things. So the point is the current health state is 120 points, not 100, so we're going to get some of that money, right? Now that's sort of the population level. You can imagine that there might be, say, a 3-part incentive that had a third from how the whole employee health plan is doing, a third from how your group, the Department of Epidemiology, is doing, or maybe the School of Public Health, and a third from how you're doing. And you could then bring this would be on the screens when you come into the building and say, oh, well, 1.2, I'm going to have a good Christmas this year. And then you could even hold up your cell phone here and see that where you are, and it would have your bonus that's tailored to your individual situation, which would be, of course, private to you, and you know what your bonus is going to be. Anyway, just to give you an idea that those kinds of things need to be done. So we have a set of milestones for year 1, which ends October 31st. First was to get ourselves going, and then a 5-year plan. The last thing I want to say is that you think that this would be interesting for Johns Hopkins, I hope, and for some of the kinds of work we all want to do. But let me just also show you this slide. This is the annual per capita expenditures on health services for all of the OECD countries, the 34 OECD countries, and that's the United States. And that difference between what we spend and what the second most expensive country in the world spends, not the median, but the second most expensive, which I think is Norway, as I recall, is $1 trillion a year. $1 trillion, it's 6% of our GDP, is the difference, not the amount we spend. It's the difference between what we spend and the second most expensive country in the world spends. Now, I gave this talk to Brown I gave this slide, showed this slide to Brown Advisories. This is like a big investment company in with a lot of rich people. You guys don't know about it because you have to be rich to be in this thing. But it's like financial advisors. And they have a meeting in Washington every year where they bring in people, and I showed them this slide, and some very rich person in the back, who happened to have been a doctor, as it turned out, said to me afterwards, he said, you really misrepresented this, because I called this waste. And he said, it's not waste, it's like an investment in the economy. People make money, people have jobs, it's like it's Keynesian economics. You're basically putting money into the economy, and it's creating places like Johns Hopkins. What's wrong with that? Well said. That's true. So maybe it isn't waste. On the other hand, right now we're shutting down a lot of other stuff, like biomedical research and other things in the government. Our businesses don't compete internationally because why? Because they're paying 28 cents on the dollar for healthcare, where the other countries are spending. Well, the companies aren't spending anything, but the countries are spending 14 cents on the dollar rather than 28 cents on the dollar. So there are huge costs to society of this $1 trillion. It's $1 trillion every year. Do you know how big $1 trillion is? It's a lot. It's a lot of money. $1 trillion is 6% of our GDP. All of the political problems, all the hassles of the economy, all of them, they would be gone if we were the second most expensive country in the world, not the first. Oh, and by the way, we're right at the bottom of the OECD countries in terms of health. Huh? Yeah. Okay, so let me just tell you who the leadership of Individualized Health is. So there's a steering committee, and this is sort of transitioning now. It started out as a bunch of influential, like vice deans for research, and people who, so Greg Ball and chief medical information officers, and vice dean for research, now the executive dean in medicine, people like that. And now it's starting to be filled up with people who know about what we're trying to do. So Elizabeth has joined, and Martha Sylvia, and Ray Winslow, and Ebony Bulware. And so we're starting to get a group of people, and their job is to steer this thing. We meet every month. We get advice from them. And then we also have an oversight committee that has, chaired by the provost, and has senior leadership from across the university. And the idea is to try to use the Individualized Health Initiative to have sort of a common theme for the university that would allow Johns Hopkins to both distinguish itself as a center of academic excellence, but also make a difference in the world. And in order to do that, we have to stop the old way of Johns Hopkins University looking to NIH, Johns Hopkins Health System looking to CMS, Johns Hopkins APL looking to DoD, and never talking to each other. We actually have to draw the resources together, because to solve these problems, we need a virtuous circle, right? A virtuous cycle. We need theory and research on the one side, we need clinical practice on the other side, and we need to make those things work together in a way that they haven't in the past. So I'm really looking for you to join this, and thank you very much for your attention. So, so N of 1 studies for sure, but if you the whole idea of so-called learning health communities is to destroy the artificial barrier between clinical practice and research. Right now, I know this may sound obscene even, but the whole system that we've built in America tries to keep research separate from clinical practice. But if you're a medical doctor, sitting across from a patient, making a decision, why shouldn't that decision be as well informed by knowledge and, quote, current best understanding as is, a paper in the New England Journal of Medicine? Why shouldn't the evidence be used to make the best possible? In both cases, we're trying to improve our knowledge and to use what we know to do the best that we can. And it goes back to the virtuous cycle. So the virtuous cycle can't exist if you put an arbitrary wall and says, oh, this is research, and that's clinical care. We need to collect information in both places, and we need the information to flow around the circle. So the learning health system needs to figure out how to do that. Well, where does the best information come from? It comes from clinical trials. But we have to have our clinical trials running, but we need to get them embedded within health systems so that we can be learning all the time. And what I'm imagining, I think what most people are imagining, is that there are 3 million patients here a year. Right? We need to be doing clinical trials with everybody. So the first thing that happens is people who come here have to understand they're not coming to MedStar, they're coming to a learning health system. And by that, it means you have to sign some consent that says, I agree that what's going to be done with me today is, I'm going to be a part of this partnership, and I'm going to give you I'm going to consent you to use my information to learn, right? And I'm also I'm willing and interested to participate in randomized trials where they're key for us to understand what to do best. And another way to say it is we're going to have a contract with every visitor, every patient, that we will use the best information from everybody who came before you to make decisions in your treatment. We just ask that anybody who comes after you be allowed to use your information as well as everybody else's. So, that's what we have to create. How to embed clinical trials in this environment, how to actually do those trials, how to use the information. Another key aspect is, I've talked about individualized health as being thinking about a model for an individual within the context of a population. And the clinical trials generate the population data. How do we actually do the trials in such a way that we have relevant information about the individuals? It's going to take much larger trials than we're currently doing. We're going to have to get data from lots of places. So trials are embedded in health systems, or actually, when I say health systems, networks of health systems need to be done, and they're going to, and the way information is gathered is going to be different. It's going to have to be gathered partly through the routine and systematic capture of data in the practice of medicine, but partly through these auxiliary studies. The way the Japanese blew us out of the water in automobile manufacturing is they made the production line into a big experiment. Right? They were learning all the time about how to make the cars better. And as part of that, they go offline and they do these very specific factorial designed studies offline in such a way that the results can then help them tune the whole system. So we need something like that. And so how to build the animal, I'm just making it up. I don't know how to do it, but this is fundamentally a clinical trials, epidemiology, biostatistics, kind of a set of problems. Yes?
How do you see the regulatory environment help advance approaches similar to what was in our university?
So
What is our, for example, common rule? There's a proposed change out there which
Yes.
may help advance.
Yes. It's a great question. I do understand that what we see today when we look at Johns Hopkins and how it operates is largely driven by the incentives from the outside. And I'm naive to think that unless those incentives change, we're going to fundamentally change a major academic health center, and certainly Common Rules is one example of that. On the other hand, if it does start changing out there, and we have to be a party to that change, we can do two things. We can demonstrate how it should be changed through our local experimentation, but we can also be ready to be early adopters of the change so that we can remain competitive when we go out. When I showed this slide about the $1 trillion, here's the bad news for Johns Hopkins. We're 0.2% of the American health care system. And 0.2% of $1 trillion, 0.2% doesn't sound like very much, but 0.2% of $1 trillion is $2 billion a year. Right? So if somebody drives that out, right, we're losing $2 billion worth of business. That's why you might imagine that Rich Grassi and people who are responsible for the bottom line of this institution aren't too excited about talking in these terms. But it's going to happen whether we do it or somebody else does it, in my opinion. And so we should be capturing part of that. We need to be early adopters so that we can lead in this century the way we led in the last century. You know, the reputation we have is because of what we did back then, right? The question is, what are we going to do today so that in 40 years or 50 years we're still a leader?
Scott, I apologize because you may have already addressed this because traffic got me here late, but where do you see all this integrating with, obviously, genetics? Maybe you talked about it earlier with that.
Yes. So the fundamental idea, so this is called the Individualized Health Initiative. It started out as the personalized or genomic medicine or genetic medicine initiative. And so this is fundamentally about that, and the genetics, we want to see a substantial growth in the basic bioscience infrastructure that enables more people to take advantage of genetic and genomic information. But a lot of these pilots, in fact, 3 of them have a major genomic influence. And if I go back, I used it to be in this analogy to a radar. This is really about the intelligent use of information. What genomics is doing is changing the kind of information that's available to us. The reason we ended up with this project rather than just a traditional personalized medicine project is as we sat around, we said, when will the genomic data fundamentally change the American healthcare system? And we said, never. I mean, not me. The leaders of the healthcare said never. And when will it fundamentally change the quality of health of the population of people that come in contact with Johns Hopkins? And then we said, well, maybe in some areas, 10 years, 20 years, 30 years. Yeah, there's some things happening now for sure, but in terms of major changes in health outcomes, 10 years, 20 years, 30 years. And we said, well, what do we have to do to get ready for that? What should we be doing in the meantime? And then people start saying, you know, in cancer screening, we don't even use the person's age. You know, when you come in, you know, the fact that you're 76 years old, you had a negative colonoscopy last year, you still get a colonoscopy when you come to Johns Hopkins. Why? Because, you know, it's good business. So we don't use the person's age. So why don't we start using age well? Why don't we make the radar system use age well? And if we can get age to work well, then we'll be able to use, you know, a genomic measure or screen. So we don't use information at all. We need to get information, all information, including genomic information.
Are there dedicated individuals who are working in Epic? Everybody's obviously worried about getting patients.
Right.
But does this initiative have dedicated people working with Epic for the research and personalized medicine kind of thing?
Yes, but not very many, and it's low on their radar screen right now because they're trying to get CMS to pay them. And when you say to them, you know, oh, by the way, so this is a big issue for us. And I got to tell you that one of the things we've done spent a lot of time, I know I'm over, in health is to work with the senior leadership to get them to understand this, that this is not trivial thinking. And you know, if you're trying to get paid tomorrow, it's, you know, October, they have to, and you're spending $600 million to do it, you know, when we come in and say, well, gee, we ought to be thinking about genomic, you know, they say, okay, great, thanks for sharing. And they keep doing what they're doing. So, but we're shaking the tree and we won't go away, and we're making progress. So hopefully you'll see decisions being made in the not too distant future that are different than the decisions that have been made till now. And you know, I've been working on this for 15 years. I was on a committee with Harold and other people who are here trying to get, you know, information systems modern here 15 years ago, and we're still struggling. But we're making progress now. Okay, thanks.